Hello everyone. So once again, as a reminder, my name is Jacqueline, and I'm doing my internship at Alon, which is a short-term rehab and a long-term nursing facility. So this week I thought it would be really interesting. My field instructor actually went to a training about a week ago. Unfortunately, I was unable to go because the agency had paid it and it had cost money. But and if I'm looking over to the side, I'm actually looking at the packet because there's some interesting things that I wanted to read to all of you. The name of it was called Challenging Geriatric Behaviors, and it was presented by Latasha Ellis. She's in MSW and LCSW. So a couple of the things I kind of pointed out, and it's a pretty big packet, and obviously if there are questions, please ask. I'd be more than happy to go through it and answer what I can. But some things I found very interesting. Currently, when we write notes in the nursing home, you always refer to their cognitive impairment by mild, moderate, or severe. And that's just how we identify any patients when we're doing like quarterly updates. So you can see if maybe they were mild one assessment and now this assessment they're moderately impaired. We can see if there's a significant change. But what she had said is now it has changed. So instead of being called a mild cognitive impairment, it's actually called a mild neurocognitive disorder. So you would still use mild, moderate, or severe, but instead of cognitive impairment, it's now neurocognitive disorder. So that will definitely help with some language. They also talked about delirium and some statistics that they have on here, which I found were interesting. And this is directly from the training, is the incidence of delirium arising during a hospital stay ranges from 6% to as high as 56%. That's pretty significant. And oftentimes delirium can be associated with sundowners, which obviously starts to happen usually after lunch. As it starts to get darker, patients will usually have an increase in behaviors. So that I found was interesting. And I'm going to point out a few other things. So when I first started my internship and we talked a lot about dementia and Alzheimer's, I always thought that it was not reversible. So whatever you had, whatever deficits, obviously we could try and slow down the deficits or the severity of the dementia, but that it couldn't be stopped. So reversible dementia, says, makes up only a small percentage of presenting cases. We never want to miss the chance to correct a reversible issue. So it says potentially reversible cognitive impairments, drug-induced depression, thyroid, B12, normal pressure, subdural hematoma. Truly reversible cases of dementia is 1 to 3%, which obviously isn't a lot, but it's definitely something. And maybe if they can figure out why they're able to reverse the dementia, whether it's a specific type of dementia or they find it early enough, I think that may lead to a cause down the road of helping more patients with dementia, which would be very, very helpful. But dementia is now a neurocognitive disorder, and that's how it's described in the DSM. So that's definitely interesting. What was I going to read? Sorry. Okay. So how they diagnose someone with dementia. So obviously their history, their genetics, so you have a higher chance if your parents or your grandparents are suffering from dementia, the chances of you having dementia are significant. Symptoms, there are risk factors, diagnostic testing, and neuropsychological testing. There's also what they call non-dementia causes of cognitive changes. So this includes Parkinson's, Huntington's, depression, HIV, other psychiatric illnesses, low B12 levels, electrolyte abnormalities, drug toxicity, infections, seizures, neurosyphilis, Lyme's disease, kidney disease. And this list definitely um, definitely goes on. The other thing I found interesting, again, is like I said before, typically I just know dementia and what dementia is, and some people know Alzheimer's, but I had no idea that there were multiple types of dementia. So I'm going to read those two. So obviously Alzheimer's dementia, vascular dementia, dementia with Lewy bodies. Definitely check that one out. It's quite interesting. We actually have a patient now with Lewy body dementia. It's very interesting, and it differs from some of the other patients. It's Parkinson's. We've all heard of Parkinson's disease, but they actually have it listed as Parkinson's dementia. Frontal temporal dementias. I guess it was formerly known as PICS. AIDS dementia, alcohol dementia, and there are definitely other ones, that go down the list. Definitely check those out. Obviously, if there's one that you're really curious about or one that you want to have more information about that specific type of dementia, ask, and I can definitely write it out, because on the slides here, it gives, I don't know if you can see it, but like Alzheimer's disease, it kind of gives information and it goes through all the different types of dementia. So if you're interested or have specific questions about the other types, please ask. I'd love to kind of share this PowerPoint with everybody. Just like I said, even though I couldn't attend the presentation, I was really happy that my field instructor brought back all the information. But I guess I will cut it off because I'm already at 7 minutes. But if you have specific questions about dementia or any of the types that I mentioned, please type them below. I'd be more than happy to answer. Or if I find other interesting facts, I may just type them in the next couple of days. All right, everybody, have a great night. Talk to you soon.